It's not 6 feet anymore.
I know, but only 15 allowed. Only 15 allowed in the lair.
So one on each side, right?
The biological.
Yeah. What?
Or you're talking about
It's only me.
No, Dan's gonna go.
We can start this
Here we can. Here we
Steam's
can.
already flying.
Here we can.
Fuck yeah, bro. It's a conspiracy.
Yeah, right.
No, we
I
can't.
wouldn't say it's that far.
Motherfucker, you should not resist.
What?
You just could not resist that, sir.
It just sounds so good, man. That's slow cooked.
What? I just watched that whole thing.
Oh, she's just gonna shake her head and like.
Anybody want some
It's
Throw it
watched,
away.
I'm not even
Just slow roast.
I mean, you're asking a vegetarian if a bat is delicious.
Honey glazed.
honey glazed? Smoked. I only want that.
I don't eat any of the swine.
So,
Birds, chicken.
this lady we were doing a training with was like, yeah, so a stroke at our facility shouldn't
I was my duck. I had one of the best duck ragouts in an Italian restaurant once. I also had a Peking duck, it was pretty damn good. Before my PT life, I worked for a pharmaceutical company and traveled a lot. And I was over in Ireland for a month, and the duck was nasty.
Really?
Yeah, it was disgusting.
Really?
Then everything in Ireland was disgusting except for the beer. No. I didn't know what I'm saying. The way they cooked it, like it was very, very gamey, very oily. And so like I'm sure you guys have venison. Like I've had venison that was, I guess, like clean kill, butchered properly, which was very tasty. I've also had venison where it was just nasty. It's gamey, so it depends on, I guess, how the kill is.
It's 90%.
Yeah, one guy was literally a butcher of a butcher, and it was disgusting. Like the venison I had. Another one was phenomenal. Like a cheese, like a venison cheese steak. So good. Yeah, so good.
Watch you say that.
Are you Irish?
I'm very Irish.
Oh, the food was disgusting. It was disgusting.
It's a whole
I'm telling you, like the beer. The beer was great. And when I was there, they were like cold, like refrigeration was just beginning.
Yeah.
So I was like, I can have a cold beer. But the European Budweiser, it's phenomenal.
It's the water.
It's the recipe is different. Like the true
They
European Budweiser is like the original craft beer.
Have you ever been to the Coors Factory though?
I have not.
It's I heard somebody
But in college, we would go to the Rose Factory.
kids that bitter taste in the back.
Come on, you're telling me when you're an undergrad, you really care what you're drinking? We would buy a case of beer, white cans, black stencil beer for $5 a case.
I started selling Kirkland brand beer, 42 pack for the same exact price as 30.
Bottles natty. It's really all it is.
42 for the same price as a 30, man.
Yeah, you don't care. Here we go.
I do not care.
Yeah, that age. Yeah. We would get we would buy 11 kegs of Genesee cream ale just so we can get a 12 for free.
You guys drink Flat off the bottom shelf?
Well, it's the cheapest of stuff. So it's all right.
Pop off.
Yeah.
Pop off and Travelers.
TC, that's it. TC's girl.
Now forget
I'd
it.
rather drink Everclear.
All right, here we go. What's going on with the affiliation? All good? You guys using anything? Any knowledge?
Yo, we were doing a lot of different things, man.
Good.
What were you doing?
Remember?
Max assist.
Tilt tables,
Oh, Universal. Yeah.
Hoyers, dude.
Yeah, my last patient was on a unit, man, like 250. Like Max
Yeah, the
assist
guy I saw
times
that
two.
dude that
And then transfer.
was awesome, dude.
Me and
The
Jeff
dude
were
was
all
moving them. Dude was huge.
I'm not patient, but,
moving.
PMR.
Fucking body.
Yes. They come in and like, we get a lot of injections. When I worked there, like, everybody got
Yeah,
like,
you get the top
Yeah,
out.
yeah, a lot of,
Okay.
like, you know, what's it called,
Sounds
hormone
good.
bags.
Even though you out.
And there's the orthopedic doctor works there, so they do it all there.
yeah, I know.
And I'm like,
Cause I had worked there, and then, you know, I was working on the patient, the doctor, you know, was like, yeah, these guys get some knots. Hold on a second, go in
It's
there.
my hands on the arch. It's my hands.
like spinal stenosis.
Actually, there's a guy, they got a printing machine, just money, ching, ching, that's what these
I'm
guys
like,
do.
I don't know.
In fact, like when I first started working there, they gave me, I would get 4 note cards. One was Blue Cross, one was Medicare, one was Workman's Comp, and one was like other insurance. And you had to bill what they told you, because they knew how to maximize the billing.
Yeah, you got it.
I never did, that's why I didn't last long. I'm like, I'm not doing it your way, I'm doing it my way.
Right, it's kind of, especially with Medicare, like you have to do like super.
I don't know, they still do it. Patient comes in, do they get like stim and heat right away? So like whoever sets them up,
Yeah.
and then you go in to treat, and then they go to the gym. So you would never, like I know for me, like I always felt the exercise was the most important part. So I would always go with them to exercise. I remember having Achilles tendon rupture. I'm like, you know, I'm watching you. You know, would start here, then progress. Okay, we'll do eccentric. And they're like, Tom, you know, there's people waiting for you. I'm like, well, if they can wait, 'cause,
Yeah.
well, you can't do that. You know, the trainers will do that. I'm like, well, and they were very good. I wasn't knocking them. But like, I want to be with my guy to exercise.
Yeah.
I want to see it. I want to
Even
see
for
it.
safety, what if they fall?
PM&R.
Yeah, I'm there, I'm in, Inglewood now, so.
Yeah, you also don't know if they're doing the exercises
That was
correctly.
a big part of it. Again, the trainers were very good, so I'm not knocking the trainers. I just wanted, maybe control. I wanted to see my guy. I wanted to see, you know, the mechanic. I want to see how he moved. You know, again, I think we're trained differently. Our eyes are different. Again, not knocking the trainers, but I want to make sure he's doing it properly. So that's why I was at the problem. But the other 90% of the old people, again,
Yeah, okay.
yeah, go see Bob. He'll give you the exercises. All right. Uh-oh. Not too long, I had a 102-year-old guy. And we would walk, literally like the tree, we'd walk like an hour.
Wow.
And the guy worked. He still worked. That's 102. Yeah.
Probably why he's still, probably the reason why he's still.
Either that or maybe the wife was like 30 years younger, so that might have helped. Yeah. All right, here we go. All right, so we're gonna cover strength and endurance, strength and aerobic or something. I apologize for setting this out this morning. It's a little hectic. Life. All good. Yeah. What's that? It's time to learn. Figure out what we can segue into. Not just jump into it. Can't. Already had it. That's part of the nice drive, like the quietness. Although I did spill it over yesterday in the car. Wasn't good. Why? Because, like, you rush. And I had a handful of stuff. I had my espresso. I put my espresso on the top. I bumped it over. It went over the place.
Oh, dude.
Yeah, but my son was with me, so I had to stay calm a little.
Oh, God, you couldn't freak out.
Yeah. All right, here we go. That's not what you said, but we'll get into it.
I'm trying again.
Let's go away.
Dan's really trying.
Yeah. He doesn't want to do anything with it. He just wants to find his apartment. He wants to go to IKEA and get his TV stand and spend like 8 hours putting together like 8,000 screws
I'm so ready. I already
that have like no regular.
Bro, I'm ready to build.
Yeah. Yeah, you got a TV stand and carpal tunnel.
So
That's
true.
IKEA.
What's that?
Okay, how does this giant, TV stand fit in a box?
It's incredible. No, it's really, it's like, it's live.
All right, so we're gonna cover strength training. In the lab, we'll do MREs, and then we'll do scenarios. We're gonna, your little groups will come up with open, closed, eccentric, concentric, isometric, isotonic, all that type of stuff that you're going to utilize over the course of your careers. So just to quickly, we did this last week, the overload principle to increase strength. Muscle must be loaded or challenged. And again, challenge your patients. You want to get them stronger, you want to get them better, you have to challenge them. Specificity, work on specific adaptations, going to create specific training effects. So if you're going to work on strength, and if you have, again, that overhead athlete or the overhead worker, like an electrician, and he's got to, change light bulbs. Well, have him change light bulbs. I think I told you guys, but I remember working with a guy, he was doing the Prudential Center when that was going up. I don't know how many years ago it was. He got getting 15. So that wasn't here. Yeah. Yeah, it was outpatient. Yeah. Still a long wow. Time flies. And again, his job, electrician working overhead. So I would have put a ladder in. You climb up the ladder, take one light bulb out, take the other one out, put that light bulb back in. So for about 15, 20 minutes, just had him working overhead. Because think about it, right? You guys know your rotator cuff, your impingement. And a lot of times we just do stuff here, I think we forget the 90-90 and working overhead. Because I need to know first of all, we need to know what the patient does. And then we need to train towards the end as they get ready to leave those specific activities, exercise, whatever it may be. Reversibility, you don't move, you don't use it, you lose it. That's true. However, I think for some patients, if you have the athlete and they have an ACL reconstruction, they'll get atrophy, but they'll gain it back quicker than like somebody that's not used to working out. And then we can utilize circuit training, high repetitions, low weight, using all modes. And it's more for general conditioning, the enormous machines, the row of machines that you have. Again, it's, they're good, they have their benefits, but we'll get into it, they're not functional. And so maybe you want to incorporate functional exercise, functional activities with your patients, regardless of age. So common errors, things you want to watch for, first off is Valsalva. Have them count, talk to them while they're working, especially cardiac patients, and most of the patients we're going to see in in most facilities, other than the younger patients, going to have some cardiac issue. So make sure that they're breathing, teach them proper breathing. Increasing intrathoracic pressure slows the heart rate, decreasing venous return to the heart, therefore increasing venous pressure and the amount that the heart has to work. So again, just have them count out loud while they're doing the exercise. Inadequate rest after vigorous exercise, 3 to 4 minutes in between to get to 90% of capacity, return to the muscle. So whatever exercise you're doing, whatever set, give them plenty of rest. Especially the older patient, especially again, the patient that has some cardiac issues. Increasing the progression too quickly, and we're going to get into that when we do cardiac, whether you increase the intensity, the duration, or the frequency. So, again, 2 sets of 10, we usually do 3 sets of 10. You want to increase it, you can go 3 sets of 12. You can also increase the weight, say 3 sets of 10. So if you're increasing the reps, the sets, or the weight, you're going to make the exercise harder. You're going to get that benefit there. And And most important to me is watch those substitute motions. I think less weight, proper motion for us is better than just trying to muscle through it. In that conversation we had last week. Yeah, you'll still get some strengthening results by doing it wrong, but I think for us, we're also biomechanists. We want to make sure they're doing it properly. So less weight, do it properly, watch the substitute motions, and also, again, identify weak, paralyzed, fatigued muscles or areas of pain, because then that might not be appropriate to strengthen. And that's why I think it's important for us to watch what they do. I guess anybody a professional? Like, don't they do that? No one's
Yeah.
professional?
Yeah.
Like in the outpatient, like those settings, like even the outpatient setting, you work with your patient and then they go, like the aide takes them out with their
sheet,
exercise sheet.
and then they do it, yeah.
And then on your own.
I mean, I agree. I mean, it was a little weird, yeah, but as a student, I got to sit with them during the exercises.
Okay, so,
You know?
so you're limited in the number of people you see.
Yeah.
But if you're seeing 4 people an hour, it's impossible to follow along because then you're sitting there all day.
Yeah, it was
You're
kind of
doing
like they
that?
would be doing soft tissue and looking over. All
Yeah.
right, 3, 4 more, and kind of distant supervision with exercises. So.
It's unfortunate that's the way it is.
Yeah, it was a mill. It was a mill,
Yeah, they're good business. They got to make money.
Brian, what office you
The
guys?
insurance.
Parsippany and Morristown.
Are you under Jim?
Yeah, I work with Jim. Yeah,
Jim, man,
Jim. Yeah, he's a minimalist. Yeah,
Meaning.
meaning.
meaning very
What-
much less is more.
Yeah, like he doesn't use. He'll never use a scraper. He'll just use his hands
Yeah, good.
and exercise. No ultrasound, no e-stim. You know.
I think he has like one
So-
ultrasound unit in the house.
Yeah, it's collecting dust. So.
Just make sure when you do it again, whatever your philosophies on modalities, and again, I hardly use them. Don't let that influence you. Just certainly make sure you know. Yeah, I know that. Just make sure you know, and we'll discuss modalities again next semester, just so you remember. Just make sure you know that for the state board. But again, once you have your license, you're on your own. To me, your hands and your brain is all you need.
Yeah.
And
I mean, yeah, he was great. He was a great
That's
guy. Yeah.
so, but I do think e-stim immediately after like a surgery, like a ACL, a total knee, I think is very beneficial.
Yeah.
But once they start to develop the contraction, then you're done with it.
Mhm.
You don't set it up. Again, the guy's doing, 300 pounds of leg press, and they finish with, Russian stim with, 5-pound weight. Like, let's do shorter quads. Wait, the guy just bench press, the guy just squatted 8,000.
Yeah.
So, all right. Yeah, so again, be involved, especially now when you're learning. Try to have hands-on in the exercise. Are they letting you guys do your own exercises?
Yeah.
Are they still in? So I told you this last year, I'll reiterate again this year. Take a few of your patients, not there, but at home, and come up with like 5 different exercises each week, just to really, make you guys think, be creative. All right, try to challenge yourself that way, just so you get better and better. All right, so exercise to improve strength, manual resistance, active exercise where one person provides the resistance. So the MREs. So you're using, like I said, as a therapist, our body weight, our strength, that becomes the resistance. I really like the MRE because it gives me a sense of how this patient's moving, how the muscles are firing. I can control it, I can make it harder, easier. I also like to do it as a game to really challenge the patient. Whether it's 97-year-old lady that I did this yesterday, or somebody younger, where again you you challenge, you try to have them, kick you off the bed, whatever it may be. But it's, again, useful early stages of exercise when the muscles are weak. Because let's say Dan had your rotator cuff repair, and we're 6 weeks out, okay, push the arm out, and it's very weak. But I can make it smooth, I can control it, I can feel that the muscle is working. So again, as a therapist, I think it's a great mode to incorporate each time. I can make it harder. I can modify it through a painful arc and range of motion. So we're going to talk about, as we get into specific protocols, that in order to progress to like the next stage, you got to make sure you have pain-free range of motion. That doesn't mean I can't strengthen. So even if I have an impingement early on and they have pain with overhead, say their pain begins like 140 degrees, there's no reason why I can't strengthen up to 90. Strengthen within that pain-free range. But I'm not going to force the strain throughout the whole range if it's causing pain. So MREs, I can use that. I can control the range that they want to strengthen in. Yeah, it's great use early on. It's safe for the joint. And we can also include diagonal patterns. And we're going to get into the PNF patterns today. And for my shoulder, again, I'll do a lot of resistance with the PNF. Disadvantage, we can't quantify the amount of force. So if I'm doing it, I know with an ankle weight, hey, 5-pound knee extensions, I can't quantify how much weight I use for my hand if the next therapist wants to do it again. Difficult to maintain the same resistance throughout, and then it's limited by the strength of the clinician. There's some guys, even though they had surgery, still going to be, 5 out of 5 strength just because. I had an ex-NFL guy, like 2 years after he retired, he had a knee replacement. And even like a week after the knee replacement, like his quad strength was like 5 out of 5. The guy was huge. It's like muscle on top of muscle. Some guys, like I said, even after surgery, they're going to be really strong. It's hard to break. So different other types of strength. You have your mechanical use of machines or apparatus. They're good. Again, I prefer the functional, but the machines are good. You can certainly get benefit. You're going to get strengthening and strength benefits from that knee extension machine, which I really hate. The hamstring, you'll get strengthening from the hamstring curl. You'll get strengthening from that. It's just that they're limited to that range of motion. They're also limited in that it's not functional. Like, when is this ever functional? Unless you're kicking field goals.
So that's a question. So if you're doing seated long arc quad with ankle weights versus doing it on the machine, what's the benefit of doing one over the other?
It's the same. The benefit is the machine is going to be a little more smoother in its arc, but you can still be jerky with your movement.
So with using ankle weights, since it's on your ankle, does that gravity have an effect on?
It's going to be the same.
It's the same.
Yeah, because your resistance with the machine, it's going to be at your ankle, just the weights go up and down. So, again, I'm not saying the machines, it's easy to use when you're in a facility that's very busy.
Yeah.
And you have the aid, okay, go do this machine, that machine. But what are you getting out of it? Right? The hip abduction, you sit on the hip abduction machine. You're going, well, that's great, but what's a better exercise? Yeah, how about bands around your ankles or your knees, lateral walk? That's functional. Especially now, we're limited in terms of the amount of treatments that these patients get. Again, I haven't been an outpatient in a while. I mean, are there still restrictions? Like, do you guys have to, for those that work in an outpatient or are there, do you have to, send the evaluation to the insurance company? They say, okay, you get 6 visits.
Yeah.
Then after 6 visits, you send it again, okay, you got 4.
Yeah.
Then you send it again and you got 2.
Even with treatment, there was limitations. Like Medicare, you can't do exercise, therapy, and a modality. You're only allowed 2 points or something. It's really confusing. and you had to like figure it out like a puzzle or like math
Yeah.
equation, and like you can't be treating someone and while like someone's on commercial and someone's on Medicare, you have to like stagger it and make it perfect, or else you get audited.
Yeah, which isn't very, I imagine, very hard and impossible.
Yeah, it's just a needless game that they're playing now, but
I guess the thing is, like in some of these facilities, they bill group, like for Medicare, group therapy instead of individual, if like there's a couple Medicare patients at once.
They try not to.
This is in the summer. So again, that's part of it too, is if you're limited, if you have, you have a person who had, trochanteric bursitis, femoral pain, and they only give them 6 visits, well, you gotta figure out what's the best to do for those 6 visits. So mechanical resistance can be measured, increase, say, knee extension machine, 30 pounds, 2x10, let's go 35 pounds. So again, you can easily quantify it. Might provide more resistance than the clinician's hands, except that they're not easily modified to functional diagonal patterns and unsafe for low levels. So somebody that's very weak might not want to use the machines. They need to have control. So for resistance, probably out of place here, but anyway, precautions for resistance training. Be careful with local muscle fatigue or even general muscle fatigue. Assess the patient, see where they are. And again, maybe you find other modes of exercise more important than strengthening if they're not feeling well, if they have an acute inflammation, or even if they themselves aren't feeling well. Not enough sleep, fatigue, you might not want to push too much. We're going to get into specific conditions where strengthening, like a post-polio, muscular dystrophy, some diagnosed like that, where actually strengthening can make the patient worse. So always assess any type of fatigue we talked about, any overwork or overtraining. And if they come in, and that's one of the things, that you got to figure out what kind of pain they're having. You might give them some exercise program, they do it at home, they come back like, oh my God, my legs are so sore, there's so much pain, what are you doing? Oh, but it's the quad, it's muscular. It's like, hey, it's a good pain, that's what you want. But you also don't want to push it if they have that type of pain. Be careful if they have osteoporosis, if they have, again, acute soreness, and then also educate them, but identify if they have the delayed onset muscle soreness, the DOMS. Okay? Maybe find other exercises that they would want to do. So you have your isometric, muscle contracts without any length change, resistance variable, and accommodating. You're strengthening only at that specific point of range of motion, not over the entire length. So early on, isometric is used if the muscle is very weak, if you want to start with some strengthening, but you're only strengthening at that one point of motion. It could also increase blood pressure, it can create Valsalva. So same thing, just be careful there. But a lot of times isometric will be used very early in the rehab. Again, we do quad sets, we do glute sets, to get the muscle firing again. But once you see that muscle contracting properly when it's supposed to, then you can progress. Unless, of course, it's a specific protocol. Rotator cuff repair, 6 weeks of range of motion, then they can start doing some strengthening. You're not going to get into mechanical or isotonic strengthening right away. You're probably going to start isometric. Isotonic, dynamic can have a constant or variable load, so as the muscle lengthens or strengthens, that load will be the same throughout. Those are the machines. They mimic that length tension curve, strongest midway. So machines are good to use early on rather than free weights because the patient has more control. But again, they're not functional. And then isokinetic, it's the same speed throughout. UBE, you set it up to 60 RPMs. No matter how hard they push, it's still going at 60 RPMs. The Biodex, the Cybex machines that you have where you don't really see them anymore because they're expensive to space. But we have in the corner, we'll play around with it someday, where you're kicking, it's the same speed throughout. Which is good sometimes for endurance, for muscle endurance. So again, if you have that athlete, that repetitive athlete that's throwing, maybe you do the isokinetic, and you do it over the course of 30 seconds and have them keep up with that same speed. So again, isometric strengthening the muscle is developed at one point of range of motion. Be very cautious with blood pressure. And you want to hold the contraction for at least 6 seconds. For isotonic, use the machines. It's the same weight throughout the entire range. So if I want to strengthen more of the end range, a machine might be good to use. Because again, it can control it. Machines are also good for eccentric control, which we'll discuss shortly. And then again, isokinetic, the machine, the same speed throughout. That duplicate? Yeah. So then you have your eccentric versus concentric. So concentric is the muscle is shortening as you put stress through it. Eccentric, the muscle is lengthening. So max eccentric is greater than max concentric. If we're looking at specificity for training, if it's a concentric activity you're performing, you want to do a concentric exercise. If it's an eccentric activity you're performing, you want to do an eccentric exercise. So eccentric occurs more within functional activities. It's more of the shock absorption in the closed chain. So if you have like a tendonitis, tendinosis, you guys know tendinosis, correct? Tendonitis is inflammation of the tendon. Tendinosis is like a degeneration of the tendon, so you have tendonitis for a long period of time, and then as that tissue breaks down, it becomes a tendinosis. So what's better? I'm treating a patient with Achilles tendonitis. Concentric or eccentric? Eccentric. Right. Eccentric exercise is better for working with tendinitis, those types of patients. That doesn't mean you can't do concentric, but make sure you incorporate eccentric. But concentric used early in the program. So concentric requires more recruitment of muscle fibers. Eccentric is less recruitment of muscle fibers. You can get more stress through eccentrically. However, it doesn't recruit as many muscle fibers. Short arc versus full arc. So short arc performed through limited range of motion. Again, good initially after a surgery or with pain, because I can control that. I can still get strengthening. However, I'm only strengthening within that range of motion. Long arc, more return to activity, more functional, strengthening throughout the entire range of motion. Open versus closed. Open, the distal segment moves freely in space. If weight bearing is limited, open would be primarily used. However, a lot of times open is not functional. Again, knee extension machine, hamstring curl, hip abductor, not really functional. Although upper body, we have to reach for something. So maybe open for upper body, open chain would be better for upper body exercises. Closed, where the body moves over a fixed distal segment. So you're loading the joints, it's more functional, stimulates more mechanoreceptors, proprioceptors. So again, you're going to have your preference. The doctor might have the preference. For certain conditions. Where'd you go? Dave. Right? He's doing patellofemoral. Right? Who's doing patellofemoral? So you're going to see for open chain for 90 to 60 degrees, closed chain 60 to 90. That's some of the research you're going to find. So for certain conditions, you're going to see that open chain is going to be appropriate for certain parts of the range of motion, whereas closed chain is better for the other parts of the range of motion. And so you can certainly incorporate both. ACL reconstruction, the difference of using open versus closed. And again, you can use both. They're both going to be beneficial. You just want to know when to use it. All right, so we get into our diagonal patterns. We'll D1. And don't worry so much about what happens at the scapula. When we do P&F and neuro, then we're really going to focus on where you start. Scapula's posterior depression, internally rotated, elbow extended, pronated, and then you finish scapular anterior elevation. We have external rotation, adduction of the scapula, we've got a humeral joint. Elbow can be flexed or extended, wrist is flexed, fingers flexed. So D1, come up across. Uppercut, throw the salt over your shoulder, some people say. D2, throw the sword. So I'll do this up here. So that's upper. So D1 flexion. D1 extension. D1 flexion, D1 extension. D1 extension is just a return to normal. D1 flexion, return back to normal. Return to the original D1 starting place is D1 extension. D2. So where D1 starts here, D1 ends here, D2 starts here, D2 ends. So D2 ends where D1 starts, and you'll see again with what goes on at each joint. So D1 and then D2. So when we do lower extremity, watch this. So lower extremity, same. So lower extremity D1 is the same motion as upper extremity D1.
Do you use lower extremity?
I do. I use D1 for hip replacements because I'm getting external rotation, flexion. I don't use D1 for anything, or D2. So D2, much harder, start internally rotating, adduct at the hip, and I'm finishing out. So it's the same motion. So flexion, so again, D1, upper, lower, it's the same movement. Yeah, I hardly use like lower, just for hip, and I just use D1. Got that? So you know your stuff, your diagonals. Like I said, don't worry so much about what occurs at each joint. When we get into neuro, that'll be more of what we need to know. But the reason why I bring it up here, because they're functional, they're diagonal. So my muscle resistance, you might have to stand. I use Devin. So if he's a rotator cuff, say impingement, he's lying down, I'm going to do my MRE, pull up, push down, pull up. So I'll do my resistance using the diagonals because it's functional. I can incorporate more of the joint than just doing flexion. Flexion. Because again, when we look at function, like, damn, I forgot to get something. Oh, you know, let me reach up and get that.
So when you do the P&F resistance, like, do you just focus more on like the shoulder joints, or do you focus on like the shoulder, the elbow, the wrist?
I primarily focus on the scapula, the shoulder. Yeah. Yep, I do more of the scapula and shoulder. All right. I think we discussed this. We'll go over it. So, indications for the resistance exercise to get them stronger, to lift, to move, right? So, again, it goes back to last week, think outside the box. Whatever you guys want to come up with, as long as you're putting stress through that muscle, they're going to get the benefits of it. However, you want to make sure that they're safe.
Those 3 points, where are we getting them?
So you're worried about it. Whenever you want to use them.
Okay.
Anytime. Whenever you want to use, you just got to remind me.
What about like the final 3?
Whenever you want. No, it's got to be a test. It can't be like an overall average.
When is that semantics? You said 3 points to use whatever we want.
Well, but if I give you 3 points on your final grade, that's like 9 points.
Yeah. That's okay.
10, because then you get like a 10% of like your project. So that's not really fair. So that simple little, 9-dot thing becomes like a grade unto itself. I can change the syllabus, 2 tests, 30, final 20, research paper 10, 9-dot, 1 day 10. Like, wow, this guy sucks. All right, where are we at here? Yeah, so just gotta be creative. Find out what they do. Use that type, their vocation, their job, their leisure, their sport, to play around. To get them stronger. I remember an offensive lineman initially it wasn't smart. An offensive line, high school kid, offensive lineman who separated his shoulder in one of the games. And they put it back in, strengthening, 2 weeks later he was getting ready to go back to play. And the big bolster we have down in the lab, the big blue one? So we had one of those in the clinic, and I had him down. He was down on 3-point stance, and I had him just explain, you know where this is going?
You got knocked over.
I got knocked, oh my God, I almost threw a window, like it was closed.
That's what you teach, not in fact.
Yeah, so I'm holding this bolster, because I wanted to make sure, as he's doing this motion as a lineman for football, that the shoulder, stays. Again, it's like, it's a couple visits before I send them back. It's like a Wednesday, after you discharge Friday, you're playing Saturday. And he comes down and he like explodes up. I flew across the room. I'm like, all right, hold on 1 sec. Now let's do it again. I'm like, bolstered down, like hanging on. All stuff like that, yeah. I've taken people out, like baseball pitchers outside and through. I met one girl and, a couple of teammates on the soccer field who was returning from an ACL, and just do soccer drills, because that's what they need to get back to. And so if I just stay in the clinic, I'm not saying I had the opportunity to do that because I just work for myself. But you might not have the opportunity. But make sure if there is a certain thing they're going back to, that they do it. Because it would be a disservice. If I'm treating a girl who had, whether it was a medial collateral ligament strain, and she's getting ready to go back to soccer, basketball, whatever it may be, and I don't do cutting drills, I don't do start-stop drills, I don't do quick turnaround, I don't do sprints, I don't know if she's ready to go back.
They're gonna get hurt.
Yeah, they would get hurt, and that's the last thing you want. To me, it's like, I hope I never see you again. That's what I say. I hope I never see you again, unless maybe you're walking on the streets. But do you want that same person over and over? Yeah. So be creative. Again, just really, be aware. What are you getting back? What is my long-term goal? And that's why it's frustrating when you're limited with the insurance, because let's just say I have somebody, they're in the acute stage, ankle sprain, and I only get 6 visits. Am I going to have that person come in 3 times a week just to do modalities and range of motion? Okay, here, this is when you come in once, evaluation, ankle sprain, this is what I want you to do. I need you to do alphabets, in and out. Here's the TheraBand. Have your mom hold the band, go different directions. Ice it, come back when the swelling is down, when the pain's gone. They come in one more time. Okay, this is what I want you to do. We're going to do single ray, we're going to do eccentric, we'll do some balance stuff. Do that on your own for a week. And then they come back and they got 2 visits left. Like, all right, now we're doing plyos, jump, now we'll do some soccer drills. And then they're done. And that's what really you have to do nowadays. It's frustrating, but unfortunately it is.
So what's your criteria to get them to, let's talk about like a hamstring strain basically. So what's your criteria to move them from like basic strengthening stuff to more functional, like, okay, now we're going to sprint?
So criteria 1, phase 1, and we'll cover this all throughout the semester. Phase 1, usually it's the acute stage. Pain, weakness, limited range of motion, edema. So phase 1, for me to get from phase 1 to phase 2, which then will be the strengthening phase, I gotta make sure pain-free, full range of motion, pain-free. They can still have edema, that's gonna be with them for a while. So we eliminate all the pain, modalities, ice, maybe it's medication, anti-inflammatories, that stuff helps early on. They finish that. Second stage, now I do my strengthening. And so certain conditions, there are criteria for when you can go return to sport. But what I'm gonna do is, strengthening wise, I'm gonna get them to where they're even with the other side. So you're gonna do your manual muscle test. You're gonna give them, all right, I want you to do bridges over the ball. I want you to do the scooter walks. Scooter walk, you sit on the scooter, you dig your heels in, right? Good for a hamstring. I'll do lunges, let's do some squats, let's do some side steps, let's do some monster walks, let's do some single leg deadlifts, let's do the star, the cones, whatever you want to do. Okay, you know what? Now they come back and they're like, wow, okay, your strength is pretty even to the other side. Now we're doing plyometric. Now we're getting back. So in certain conditions, like that, like a hamstring strain, like a patellofemoral, there's not going to be a specific protocol as to what to do week 1, week 2. ACL reconstruction, rotator cuff, they've been studying that for years. There are specific protocols. Non-weight bearing after a hip fracture, I know 6 weeks. You're gonna be non-weight bearing. Then I know after that they might do partial weight bear, then full weight bear. So for those conditions, we know there's a timetable. Other conditions, we don't. We're going by like that, like sort of that protocol. No pain, full range of motion, and that might be one day. You might have, like I said, like a hamstring. 2-3 days later, the pain's gone. Then I can get into the strengthening. You might have other patients where it takes 2-3 weeks. Depends on the severity of it. Really depends on how motivated or how much this patient can tolerate. All right? Answer the question? So, and again, that's like the fun part is you gotta, again, always assess and see where the patient is. Every time they come back in, you can do a manual muscle test, do your range of motion to see where they are. I'm like, hey, you're doing real good. You know what? We're gonna bump it up. We're gonna challenge you today. But again, all within what they can do with the range of motion, with the strength, pain, that type of stuff. Making sure it's proper, proper mechanics, right? None of this. Like, hey, how you doing? Like, oh, look at him, doing great. All right. And then there's plyometric. Plyometric would be used in that final stage. The explosive exercises, the return to sport. My basketball player who comes in with patellar tendonitis from jumping, we get rid of the pain, he's getting stronger, and then I say, see ya, and he goes to a game, but he hasn't jumped yet. Well, I better make sure I do some of that jump. Maybe the 80-year-old, knee OA, I'm not so concerned about plyometric type stuff, unless you want to. Have to do some muscle ups.
Nice.
So as I'm driving this morning, taking my son to school, he's like, what do you think? You think the muscle up is the hardest exercise to do? I'm like, it's pretty damn hard. I mean, I don't know if you can say one's specifically harder than the other. What do you think?
Iron cross.
You can get some pretty good momentum with the muscle up. So if you learn that swing and that kick,
Yeah.
It's intermediate.
So for those, a muscle up is like a pull up,
hard.
right? But you pull up and then you like lift yourself up and over the bar, and you come down.
I would say, like, this is something I used to train all day, it's more of a skill set because if you have the strength to dips and you have the strength to pull up, it's really just that transition phase is the hardest.
Yeah.
So,
That's what we're trying to figure out. Like the hardest exercise to do.
It's the iron cross.
For me, it's like
Yeah, iron cross is very hard, but that's your shoulder though.
Yeah, but it's
Still
hard.
very hard, I know.
I mean, and
Unless you're, the one guy that does it amazingly is, and I can picture him, Vince Vaughn.
Vince Vaughn?
Yeah, he does it with a cigarette too.
Vince Vaughn does the Iron
As
Cross?
in like, yeah, as in like old school. When Vince Vaughn is doing the iron cross.
No, no. Oh, no, no.
That's trying to figure out what's the hardest exercise. But yeah, his muscle ups is pretty hard.
No, no way.
I don't think the muscle ups are that complicated. For me, it's like a single leg RDL, like a loaded single leg RDL. Like that's way more difficult for me.
Yeah.
I would say like, like the four glute hamstrings, like one, like use your body weight, come all the way down.
Nordic curl.
How about this? How about this? We get another conversation. If you're seated, so if you're down on the floor, standing up without using any assistance, would you consider yourself being fit?
Oh, what is it? There's
No, you would say no?
Alright, Casey, go ahead, try it.
Without using your hands. So you sit on the floor, you can't use your hands.
Did you cross your legs?
Well, but you can start crossing your legs, and then you can come up however you want to come up. But you're not using any support.
Like Jackie Chan, like a ninja?
Like that, not that. Without using your hands, you come up. Yeah. Yeah, stand up. Right, so by that, would you consider, if you can do that, would you consider yourself fit?
No.
I didn't know.
I said yes.
Wait. You're mobile.
So, I'm not talking fit like that, that you can go run a marathon. But if you think about it, you need range of motion, right? You need core strength, you need lower body strength, you need stability. So I said, yeah, I would consider yourself, if you can get off of the floor, that I would consider you in, pretty decent shape. Because of all the factors of range of motion, of strength, of coordination.
The Russian ghetto.
The Turkish get-up. Turkey, that's pretty, that's a good one though. I do like that
You're also
exercise.
using momentum, there's other factors, like with that, I didn't just stand right up.
No, but you still need the range. I can't do that because I don't have the range of motion. But I think when you incorporate all that other stuff,
Yeah.
you sit on the floor, if you can stand up, pretty good. You should be proud of yourself. And that's just me saying that. That's not like any report, all right? I will try.
Sorry, can you define, like, when you say the word fits,
So I'm using the term fit as somebody who has good range of motion, who has good strength, good coordination, good stability, adequate strength, stuff like that. I'm not putting it up there like, hey, I can go, you can go out and run miles or sprint or No, I think it's more than that. Functional. Can do functional. That's my definition. That's nothing in a book. That's what I feel.
12 feet.
It is. That's it. It's very subjective. So, all right. So plyometrics, the capacity of the muscle to exert a maximum force output in a minimal amount of time. It's like that coin. You take a spring, a coil. You compress it. You let go. It bounces up. So it's a type of exercise or activity that's going to really use a lot of power. We use it during the advanced stage of rehab, that final stage before they go out and go back to sport or competition. So they're quick, powerful movements involving pre-stretching of the muscle, activating that stretch, shortening cycle of the muscle, the GTO, increasing the excitability of the neurological receptors, improving the reaction time, and really getting it to explode. So in order to really perform the plyometrics, you need that good neuromuscular control, which is why it's towards the end of the stage. And that's what you're going to watch. We have our basketball player. If you see that muscle is not firing properly, you're not gonna do this yet. You're gonna keep working until you get that muscle firing. So you have your first is the eccentric or the stretching or setting phase. So if I think of a jump, I load down, muscles, those quads are stretching. Amortization, the time between the eccentric and the concentric, it's that brief period of time before I switch from shortening to the explosion, which then is the concentric response, where that muscle then just explodes. Again, it's not used for everybody, but it certainly needs to be used for your athletes, especially at the end phase. But we're looking for the precautions, any type of acute inflammatory phase, pain, we don't want to perform it. Immediately following post-op, and then if they have instabilities. So again, it's got to be where they're strong enough, they're stable, they're coordinated enough that they can perform the activity. If we're performing plyometrics on somebody who doesn't have that, we can re-injure the person.
Yeah, so what is power is like strength plus velocity equals power.
Yeah.
It's like building the strength first and then,
Yes.
applying that strength
Yes.
and that power.
Yeah, build the strength. If you don't have the strength, you're not going to be able to, to do the plyometric. You're not going to have that power. So you got to build the strength first. And again, it's not a certain amount of strength. It's obviously strength for what that person can do. Let's say you have the long jumper in track. It's a plyometric, that type of jump. But that's not saying that that long jumper is stronger than the basketball player. It's obviously relative to what activity, what sport they're performing. Well, it is, but I mean, power is still power. But yes, it's again, that's the specificity. So, all right, review, we talked about that. Endurance training again. So we also want to work on the muscular endurance, the ability of a muscle to perform that repeated contraction over time. When do we get injured? Muscle breaks down. Right, with fatigue. You look at all the studies on baseball, people that get injured from throwing. It's not one specific motion. It's they start throwing, and then by the 5th inning, after 90 pitches, arm starts to drop, mechanics change. That's when you get the injury.
Is there more baseball injuries now than ever? Like there's a lot of hamstrings. And, what's going on? Are these guys just not training any type of explosiveness?
Baseball's a soft sport.
Are they just
Baseball players stuff their toe in their
Yeah, what's going on?
like 6 months.
Maybe they're just
You know what I think it is? Honestly, I think it's overtraining.
Yeah.
Because when you look at baseball, or even all sports now, I'll even equate it to football. When you have a 320-pound lineman should not run a 4.840. It just doesn't happen, but they do.
And they can jump out of
And so I think when you look at the science behind what we do now compared to 20 years ago when I played, with, again, specificity, with diet, with the, your blood work and enzymes and all this stuff, it's specific. So I did work with the Giants at their Giant facility a few years ago.
Did you know Mike Dunn?
I did.
The PT? I worked with Mike.
Yeah, that whole group, yeah. And it's unbelievable. Nutritionists on staff, just the whole thing of, sport and, the strength and conditioning coaches, the dietitian. I mean, these guys are so spoiled, it's incredible.
Did Dunn wear the thimble?
So I didn't see, he wasn't training, he wasn't working much when I was there, because I was actually treating one of the coaches. Yeah. And so he's like, well, I gotta work, and you come to the Giant facility. I'm like, all right, I'll be there every day. Every day I was there treating him, it was awesome. Just hanging out,
Yeah, when he treats throws on the thimbles, man. It's so funny.
It was awesome. But I think that's the difference, it's so specific nowadays, it's so scientific. That they know specific, you're a lineman, you're doing this is what your diet needs to be, here's your shake. For soccer, who follows soccer here? European soccer, I know you do. You know what these guys have on their jerseys? Yeah, they have GPS.
They look like ball straps.
Yeah, so they have GPS. So you got a guy, you got a scientist, a therapist, an exercise physiologist sitting up, let's take, Paris Saint-Germain with Messi, on their uniform. Their uniform has a GPS in it. It tracks how many miles they run. It tracks their heart rate. It tracks how much they sweat. So they look at it, he calls down, he's like, hey, Messi's at he only got 20% left of energy. And they pull him out. Maybe not Messi, because he's just that good. Somebody else. But that's how the science has become.
Yeah, college football programs do that too.
College does that
And they
too
look
now.
at every single player,
Yeah.
the recovery.
Yeah, and I know some club baseball teams that are looking to get into that. This is which is asinine, but whatever.
When I was
It's all bells and whistles.
I was shadowing at Rutgers, and all the sports have that.
Yeah.
So they have exercise physiologists for practices, just for easy stuff. No, your heart rate's too high. What's going on? Are you sick? Do you have an injury? Did you drink too much last night? And if their vitals are not
Yeah.
consistent, they get pulled out of practice.
I was throwing up in some practice in college, I didn't give a shit.
Half the time you probably should. Well, it's baseball. Some guys did better drunk in baseball anyway. But that's the technology. That's the difference. So why are athletes getting injured more? I think because they're overtrained. You never saw oblique injuries in baseball. But when you Judge, Stan, these guys that are so fit, that are so, toned, and when you look at the velocity and the force of the rotation, the muscles can't hold that. So I think that's a big part of it. They're too big, too strong.
One of the things that, maybe 4 or 5 years ago was a big thing with the NSCA was we were talking about a lot of what we're doing with kids athletes, baseball being an example. The average pitching, I think they said they took for a sample size of, I think it was 150 games, which is a small amount of games, but for 10-year-olds was 97 pitches. The 10-year-old should be throwing 97 pitches.
I got very involved in baseball with my kid. He plays at a high level. And I remember being involved in games. And I personally did not have, my kid pitches, but he's not a pitcher. Meaning, hey, you need somebody to throw a couple of innings, send my kid in. And it's more of a selfish reason than anything else, not injury. Just because I pitched in college and I pitched the game, then I sat for the next 4. I'd sit there, I'd juggle. I learned how to blow bubbles. Hubba Bubba with Bubble Yum would give you the biggest bubble. I blew bubbles in bubbles in bubbles because I had a lot of time. And I'd sit there, and then I'd go and I'd pitch, and I'd sit back. And I'm like, dude, pitching sucks. It's exciting because you control the game. It's boring because then you sit for 4 or 5 games, and then you go back out, play a different position, and then you became catcher. But I've seen 120 pitches because they had to win. It's insane.
A lot of tips.
And I don't want to be a hypocrite because my son will catch 6 games over a weekend because there's no other catcher. So he's throwing as much as the pitch, not as hard. So I am hypocritical. But yeah, it's I think your arm only has a certain number of you only have a certain number of throws. You want to use them up early or late.
But now you have to worry about his hips because he's in that squat position for extended periods of time. He needs good mobility down there.
But see, he's skinnier. I was heavy when I always played baseball, so I think that might have led to early hip replacements.
Oh.
Yeah, he's skinny.
Okay, so you could do it. No worries.
Yeah, no worries. He doesn't eat. I
Doesn't
eat.
eat.
You had
Oh, no.
hip replacements?
Yeah, bilateral, yeah.
Oh, wow.
Anterior or posterior?
Posterior.
Okay.
Yeah. This one actually was only a 10-year lifespan. I'm on 15. Yeah, it's phenomenal.
Is ceramic or metal?
No, it's metal.
You have feet every time you go to the.
I do. My wife hates it. Can't stand it. And then she has to take care of all 3 kids. So now they're on their own. So
Don't they tell you to go on the other side?
They didn't have, years ago, they didn't have that thing, and I knew, we were traveling, little kids, and
You know you loved it.
I know. And so I'd go through, beep, I go over there, and they're winding me down, and she's like, this, like a little kid, I'll go put your shoes on, I'd be like, Like, all right, you got everybody good, let's go. She's like, Swen, you suck. Not my fault, it's plain TSA. Love to help you. But, then she doesn't realize that once we land, it's like, I got like 9 bags. And, whatever. All evens out. None of that. All evens out. All right, so again, muscular endurance. So we improve it by performing low load strengthening for repetitive. So again, we have that overhead athlete, the overhead worker, whatever it is. The guy that works on paint sealing, painting, he's doing this all day long. Well, you know what? We can do our TheraBand. Okay, I want you to do this at a time of 30 seconds. And I'm there. Keep that elbow up. You got to keep it up and build up. So muscular endurance. Again, indicated after injuries, joint, soft tissue, high reps, light resistance. That's going to be the key. We can also work our strengthening, low reps, high weight, but also endurance, high rep, low weight. Cardiovascular endurance, the ability to perform large muscle dynamic exercises. Same thing using the overload principle. Even as simple as somebody who had a heart cabbage, the graft. I remember that in certain cases you always remember. This was like a 48-year-old guy had just like tattoos everywhere. He went and got another tattoo, got an infection, destroyed his heart. He was like 6 months in the hospital on LVADs, the left ventricular assisted device, where basically the machine is pumping your heart. It's like a big machine, like 5-pound battery that you got to carry around if you unplug it. And he ended up getting a heart transplant. He had the heart transplant of a 30-year-old triathlon runner who had died of an aneurysm. So he comes home, I go there, first treatment, I would say we walk from the chair to the bathroom and back, and he's exhausted. 3 months later, we ran a half a mile.
Wow.
Yeah, pretty remarkable. I mean, it was all him, he pushed himself.
Yeah, but that heart though.
But it was pretty remarkable, yep. So don't get tattoos.
That was already planned.
What's that?
I said, guess I'm not.
Yeah, this is for us.
I'm just kidding. It's your, my daughter wants to get a tattoo, and she hates needles. I'm like, I'll go with you. I'll even pay for it. But she's like, we'll get one together. I'm like, yeah, I'm going to get a tattoo. Like, really? It's going to be hidden. It's a waste of money for me. I mean, come on.
Get on the forehead.
Yeah, exactly. Get one on the side of my neck. So, all right. Yeah, so that was pretty cool. A half mile we ran. It was remarkable. Like I said, but a tribute to him because he wanted,
He was compliant.
He wanted it. So I called the doctor. I'm like, listen, I need a protocol. I need to know how much I can push. Yes, I'll still monitor heart rate. He's like, listen. He's like, we don't do a lot of these. We have no protocol. So if you come up with something, send it to me. I'm sure every heart transplant is not going to be running a half a mile.
Yeah.
But yeah.
So did you send him a protocol? The Donofrio protocol?
Yeah, I said go out and run. Yeah,
no.
I stayed away from that.
Treatment.
I'm like, I don't know. We just, went for a walk, and then it was a further walk, and then it was one walk around the track, because you live right behind a field. And then we did that, and it was a half. Then we walked a mile, and then we ran.
But it kind of goes to show, like, if you gain strength and you lose it, it's easier to gain it back.
And he said he would work out. He was a gym rat. So I think that was part of it too.
Yeah.
So he also had 6 months, but I still think there was some muscle memory left that he was able to get back to that point. But it goes to show you, regardless of the age, regardless of what the condition is, you can improve the endurance. That older patient that's been pneumonia, bedbound for a while, by pushing them, by taxing them, they'll get better. And it's what we talked about with the endurance. Doesn't necessarily have to be 15 minutes at one time, break it down. But the difference is, and you guys have seen it, if you have a patient that wants to get better, you're gonna get better. The only difficult might be the one that's too gung-ho, where they're like, I'm gonna do 500 squats because I'm getting better faster. Well, that's harder to treat because now you gotta control, keep him back. I have a guy, I discharged him today, 2 weeks after the knee replacement, he's at 130, 140 degrees, and he pushed it. But when you look at his knee, it's like a giant balloon. There's so much edema in there because he pushed it too much. So I'm like, all right, well, that's great, you're at 140 degrees, you got full range of motion, finally knee replacement, but now you gotta go back and get it drained. So, yeah. So again, as much as you need to push your patient, you need to know those patients to control the reins and let them know, no matter how much you do, your body needs to recover. It's great that you want to work out, it's great that you want to push yourself, but you need to control it. You need to tone it back a little bit because you can overdo it. Another patient, he did simple as massage. I'm like, all right, now you can start using some vitamin E on your incision to break up the scar tissue. I go back like 2 days later, she's like, yeah, I've been doing it, I do it like an hour a day. She had cellulitis because she pushed too hard. Like, all right, well, a little too much. So also pulmonary endurance, build up the strength. So who has treated patients following bypass, valve replacement? You see that?
At university and at Hackensack.
So those patients, right, they rip the sternum open, they get these giant like jaws of life. It's pretty wild. Like how but it's like barbaric the way they do it. Like they turn it slowly and it just rips the sternum in half. So they get valve replacement, they get their bypass. That's fine. It's like getting a tooth pulled nowadays. But then they wire you back together. With a big staple gun, yeah. And then, now all of a sudden they come home, you see the patient, and they have a hard time breathing. Well, what happens when we breathe? What do the lungs do? And what do the ribs do? They expand. They go out, they go up, and they go AP. So they have to expand. It's like a bucket, and you get the handle. Well, if I had a surgery to my chest, even as simple as a patient that fell and fractured their ribs, has anybody had that? And how painful, or anybody yourself have done it? How painful is a fractured rib? There's nothing we can do. I can't brace it, I can't put a cast on it. They just have to suck it up. But they take a deep breath, it's painful. So, in order for them to really improve that pulmonary endurance, that pulmonary ventilation, we need to work on those breathing exercises. We need to get those lungs to expand, to get the ribs to expand. Because if those ribs can move, and move up and out, then the lungs can move up and out too. The more oxygen I get to the lungs, the more I can circulate it. So with our patients that had surgery, every patient, after surgery, after bed rest, breathing exercise, very important. Get those lungs moving again, get those ribs moving again. We're working on pulmonary endurance, the ability to bring the oxygen in, get the CO2 out, breathing efficiently, effectively.
And they'll give a lot of the patients those spirometers.
The incentive spirometers. Everybody know the incentive spirometer. That little plastic thing with the blue tube. Either you have the 3 balls in there or the line. It's the treadmill for your lungs. That's what I tell my patient. Just as much as I want you to walk when I'm not here, 5 times every hour, take that deep breath. Get to 1,500. Next week, I want you at 2,000. Then I want you at 2,500. You get to 3,000, then you're good. But that's what it is, right? That incentive spirometer, great to strengthen the lungs. We have muscles that help us breathe. Yeah, we want to get big biceps. We also want to get those muscles strong to help breathe. More efficiency for the patient. Aerobic training, you have your cardiovascular, your cardiorespiratory endurance. Again, walking, but walking at a high rate, getting your heart rate up. Bicycle, walking in the pool with that resistance. Improving breathing volumes, increasing heart rate and volume, increased total hemoglobin oxygen delivery, improving the heart rate. And we'll get into specific protocols with that cardiac patient, how much we need to push the patient. But I want to get the person to be able to walk further, I got to walk them further. I want to get the heart stronger, patient with congestive heart failure. Now they take medication, the Lasix, get rid of that fluid. In order for me to get that heart working strong and proper again, I need to stress that heart. I need to make it work a little harder than it normally does. And we do, through the heart rate. Very important, the principles are warm up and our cool down. The warm up prevents the heart and circular system from just suddenly being used. Gradually work up into it. For us, we can go out and run. Like I said, I've never stretched. Went out and ran 4 miles last night, put my watch on, get my dog and go. No warm up, I'll warm up along the way.
Oh man, I don't know about that.
That's me, I don't have the patience for a warm up.
You gotta warm up.
Yeah, you start slower, I go, I got
After the first one,
time constraints. And then a cool down. Cool down, very important. It prevents the abrupt physiological alterations. It prevents pooling of blood in the extremities. So with our older population, we're concerned about blood clots, we're concerned about poor circulation, venous ulcers, venous deficiency. The cool down, so slowing the exercise, if they're on a bicycle, going to 60 RPM, just slow it down. This prevents pooling of blood in the extremity to prevent the clots, to prevent any type of stasis problems. So again, for our older population, for our injured people, people that are ill, warm up and cool down before the exercise. Is that everything? There's one more?
Errors.
And then common errors, starting out too high, increase the intensity too fast. The worst thing we can do is push them too fast, especially someone that's never exercised, because they ain't coming back. Exercise too low of a level or too high of a level, insufficient warm-up, cool down, and then inconsistency with that duration, with the frequency. And that's why it's more important for you guys to follow through with the patient. Or if not, if you're in the facility that doesn't have the capability, you send it with the aid, just make sure you review that sheet. Again, so many times when I would go on the clinical affiliations and follow you guys, I would see the exercise sheet and I would see the pulleys and the quad sets like 3 months after they started, yet they're doing lunges and other stuff. So change it, right? Make it somewhat interesting for the patient. See where their strength is, make sure you're challenging them. Slowly add the balance, dynamic, coordination, agility type stuff as well. Alrighty? Let's go to lab. Any questions here?